Alrighty, I believe I have the right view here. So, good afternoon, everyone. My name is Yue-Harn Ng. I am a transplant nephrologist at the University of Washington. So, for today's patient webinar, I'd like to take you through the kidney transplant evaluation process. So, in the next 45 minutes or so, I'd like to cover three major areas. The first one is what transplant centers are looking for in the transplant candidate. In other words, what makes a person eligible or ineligible for a kidney transplant? The second part, I'll talk a little bit about what to expect during a kidney transplant workup. What are some of the workups that we do as part of the kidney transplant process? And the third part, I'll be talking a little bit about what to know when someone is thinking about becoming your living donor. So, as many of you may know, kidney transplant patients survive longer than patients who stay on dialysis. So, this graph here is basically a Kaplan-Meier curve that was obtained from a study that was published in the Journal of the American Society of Nephrology way back in 2000. And this data actually hasn't changed at all. So basically what this graph here shows you is compared to patients who stay on dialysis, as shown in this horizontal line here. Patients who received a kidney transplant, whether they receive a standard kidney, as shown in the dotted line here, or even if they receive a marginal kidney, a kidney that's not of perfect quality, patients who receive a kidney transplant survive better compared to patients who stay on dialysis. So anything below the horizontal line is better survival. And you will see here, patients who received a kidney transplant do better than patients who stay on dialysis. But that's not the only benefit of a kidney transplant. We know that kidney transplant patients also have better quality of life compared to patients who stay on dialysis. And it's for these two major reasons that anyone with advanced kidney disease, anyone who's on dialysis, we try to encourage them to consider kidney transplant as one of their treatment options. So the first step in the kidney transplant evaluation process starts from the kidney transplant referral process. And as Doris has mentioned, our colleague Prince Tenoso had given a wonderful patient webinar a few months ago on the kidney transplant referral process. So I won't be spending too much time talking about the kidney transplant referral. But I would like to emphasize to everyone that the earlier a person is referred, the better it is. And why is that? The reason for that is because we know that the longer a person stays on dialysis, the higher the risk of kidney failure after transplant. This is a graph that was obtained from a study that was published in 2019. It's a French study. And in this study, what the authors did is they looked at patients who had a kidney transplant and how much time each patient had spent on dialysis before transplant. And what they found in the study is the longer a person stayed on dialysis before transplant, the worse was the graph outcome after transplant. So for that very reason, we try to encourage patients to be referred as early as possible so they can start the transplant process as early as possible to minimize their time on dialysis. The KDIGO guidelines is a set of guidelines that many transplant nephrologists and nephrology follows. In other words, it's basically our Bible, and it gives us guidance in terms of what we should be doing for our patients. And in the KDIGO guideline, they basically say that a potential kidney transplant candidate should be referred for evaluation at least 6 to 12 months before anticipated dialysis initiation. And the reason for that is this will allow for time for identification and workup of a living donor and plan for possible transplantation before the need to start dialysis. So in other words, for preemptive transplantation. Preemptive transplant is a word that you may hear me saying or your doctor saying to you. And what it basically means is getting a transplant before needing to start dialysis. Again, it's never too early to think about finding a living donor. So what are the things we look for? As a transplant center, what are some of these things that we look for to see if a person is eligible for a kidney transplant or not? Well, we know that kidney transplant is the best treatment option for patients with kidney disease. Unfortunately, not all patients may benefit from transplantation. Any patient with reduced life expectancy due to their underlying irreversible medical problem should not be referred for a kidney transplant. And I'd like to emphasize the word irreversible here. So again, going back to the KDIGO guidelines, basically what they have recommended is a series of medical conditions that perhaps if the patient has these medical conditions, they should not be referred for a kidney transplant evaluation. And I know there's a lot of jargon here and there's a lot of words here. I'll walk you through some of them. So patients with multiple myeloma, with light chain deposition disease, heavy chain deposition disease, AL amyloidosis, what these are basically blood cancers. So patients with these medical conditions, if they did not receive a curative treatment, perhaps may not benefit from a kidney transplant. Anyone with decompensated liver cirrhosis, so anyone with severe end-stage liver disease, if they did not if they were not considered for a combined liver kidney transplant, then they probably would not benefit from a kidney transplant alone because they have severe liver disease that would shorten their lifespan. This is the same for any severe irreversible obstructive or restrictive lung disease, any severe uncorrectable and symptomatic heart disease that is deemed by a cardiologist to preclude transplant. Again, these are all end organ disease. And if the doctors do not feel that the patient would benefit from perhaps a lung transplant or a heart transplant, then these patients probably would not benefit from a kidney transplant either, because with those conditions, their lifespan is shortened. Anyone with a progressive central neurodegenerative disease may also not benefit from a transplant. So you may ask me, well, how short exactly is the survival of these patients? So if you look at the survival of some of the conditions that I mentioned before, you will see that the average survival or life expectancy of this condition ranges between 6 months to 36 months, so between 6 months to 3 years. And when a person has a shortened life expectancy like that, it is unfair for us to put them through the vigors of transplant, to have them experience the side effects of the immunosuppressive medications, only to not reap the benefits someone would experience from getting a kidney transplant. So if a person has this condition and cannot have curative curative therapy, then it is in the patient's best interest to have a shared decision-making process and a discussion with their team, their medical team, to see what are the goals of the patient and what is the best treatment course for this patient. Now, there are some other medical conditions where the transplant team may say, well, you're not the best candidate at this time, but if your condition can be treated and reversed and it remains stable after, you may be eligible for a kidney transplant later on. Now, some of these conditions include an unstable psychiatric disorder, whether it's severe depression, severe debilitating anxiety disorder, or unstable bipolar disorders. This patient perhaps should not receive a transplant at the time when they're having severe disease, but if they can be treated and stabilized, they can undergo a kidney transplant later on. The same goes for ongoing substance use disorder. If someone is actively using substance, including cocaine, heroin, someone who's actively smoking, uses marijuana, or excessive alcohol, these patients may not be a transplant candidate at that moment, but with treatment, after undergoing therapy, and if they can demonstrate that they are in remission, they can be considered for a kidney transplant later on. Same thing with health compromising non-adherent behavior. It's not uncommon that transplant centers get referral for someone who perhaps received a kidney transplant when they were a kid and lost their transplant because they stopped taking their medications. When these patients grow up, they come to us in the adult kidney transplant setting, and we will definitely evaluate these patients. And if they can demonstrate that they are now adherent to treatment, adherent to dialysis, we will consider them for kidney transplant as well. Other conditions include active infections, active malignancy, if someone has active symptomatic heart disease, peripheral arterial disease, anyone with a recent stroke, any active peptic ulcer disease. So again, if someone has an active medical condition, they may not be eligible for a transplant at that moment, but if they can be treated and the condition remains stable, then they can be considered for a transplant. So, in other words, someone with a reversible medical condition may be transplanted if their conditions can be fully treated. Now, once there is a decision to refer a patient for a kidney transplant and the patient comes to us for transplant evaluation, what would a person expect in terms of the kidney transplant workup? So one of the mainstay of evaluation is a heart evaluation. Now, why is that? We know that heart disease is the most common cause of death in our dialysis population, and the incidence of cardiac or heart disease increases as the kidney disease worsens. The prevalence of heart disease in our hemodialysis patient population is about 40%. And this is compared to only about 8 to 13% in the general population. So you can see that it's about a 2 to 3-fold increase compared to the general population. And patients who are on dialysis have a 10 to 30-fold higher risk of dying from a heart condition compared to the general population. And it is for this reason that we feel that a heart evaluation, a cardiac evaluation, is very important for our patient population before they can undergo a kidney transplant. Now, having said that, the optimal way we assess our patients for heart conditions, including the screening tool we use, how frequently we screen our patients, and what is the best treatment option once we diagnose a heart condition, remains fairly controversial. And the reason I say this is it really is fairly center dependent. So it's very important that you discuss with the transplant center in terms of what kind of workup is expected of the patient when they undergo a heart evaluation. And really, there's no need to compare what you're doing with perhaps your friend at dialysis because the type of workup may be very different. I put here the KDIGO guideline again, basically to emphasize that even with our guidelines, they don't tell us exactly what to do. They say if a person is symptomatic, they really should be assessed by a cardiologist and be managed according to the current local cardiac guidelines. So talk to the team about what kind of evaluation a person will have to undergo for their heart evaluation. But in general, if someone is fairly young and someone has a short duration of dialysis, or perhaps someone has never been on dialysis when they were evaluated for a kidney transplant, we believe that this patient population did not have the time to develop heart disease. So in this patient population, the risk of heart disease is lower. And because of that, usually this patient population does not require a lot of cardiac evaluation. They perhaps will have a history, a physical exam, perhaps an electrocardiogram, but not an extensive cardiac evaluation. Now, that's not the majority of our dialysis population, however. The majority of our dialysis patients are middle-aged to older. They have multiple risk factors for heart disease, including diabetes, high blood pressure. Some may even have had a heart attack before or had a stroke before. So how do we evaluate that population for heart diseases? In 2012, the American Heart Association modified their recommendations for kidney transplant candidate, and they suggested that a non-invasive stress test is recommended for a patient, even if they don't have any active symptoms, but they have at least 3 risk factors, regardless of what their functional status is. And these risk factors include diabetes, prior heart disease, if they've been on dialysis for more than a year, if they have left ventricle hypertrophy, meaning if the left side of their heart is enlarged, as seen on echocardiogram or ultrasound of the heart, if they're above the age of 60, if they're smoking, actively smoking or has a history of smoking, if they have high blood pressure, or if they have high cholesterol. So as you can see, many of our patients actually have some of these risk factors or have more than three of these risk factors. So in this patient population, it is recommended that the patient undergo stress testing. And so for our kidney disease patients with high risk for coronary artery disease or for heart disease, usually they will undergo non-invasive stress testing, or sometimes in someone who the team deems very high risk for heart disease. So for example, someone who had a bypass before, or someone who's had a heart attack before. Sometimes these patients, the transplant team may say, well, we think your risk is very high, so let's do a coronary angiogram and see what your blood vessels in your heart looks like. How we manage our kidney transplant patient really is a balancing act. Kidney transplant patients will receive a kidney from someone else. And usually, when this kidney is put into the patient, the body's immune system is really smart. The body's immune system will immediately recognize that that kidney is not their own kidney. So it will try to reject this kidney. So a big part of the post-transplant care is putting patients on immunosuppressive medications that will suppress their immune system so that they can't reject the organ. But when the immune system is suppressed, it also means that these patients are more prone to infections and they're also more prone to cancers. So adjusting anti-rejection medication really is a balancing act. We don't want to give someone so much immunosuppressive medications that they experience side effects of the medications. We also don't want them to be so weak that their risk of getting cancers and getting infection is higher. But at the same time, we also don't want it to be so little that the person rejects the organ. So trying to find that balance is very important. And this balancing act actually starts even before a person is transplanted. So another big part of the pre-transplant evaluation process is screening for infections. This is a very colorful diagram here, and I know the writing is very small, so I don't really expect anyone to be able to read it closely, but I'll walk you through it. So this graph here basically shows the types of infection a person can get after transplant. And it goes from the left, from immediately after transplant, to the right, which is further down, further away from transplant. And what you will see here in the first column is within 4 weeks of transplantation, the most common infection that a person can get is possibly a donor-derived infection. So an infection that perhaps the donor organ already has and could be transmitted to the recipient. Another kind of infection that a person can get immediately after transplant are infections that are related to the surgery itself. So for example, if a person has a urinary catheter, then this person may be higher risk for getting a urinary tract infection. The patient is intubated at the time of surgery. So post-transplant, pneumonias can happen because of the intubation process and because of secretions and lung collapse during the intubation process. Other kinds of infections include wound infections because the transplant surgery does involve a wound. So wound infection is another very common infection that the patient can get. So those are some of the infections that the person can get immediately after transplant. Within 1 to 12 months after transplant is the phase where patients can get reactivation disease. So what does reactivation or relapse disease means? Usually, unlike a bacterial infection where we give patients antibiotics and the bacterial infection goes away, many infections can stay in the body and they tend to stay dormant in the body because our immune system is strong and we can keep these infections dormant. That's not true when a person has a transplant and I suppress the person's immune system. When I suppress a person's immune system, some of these latent infection that a person got when they were a kid, or perhaps even in the remote past as an adult, can reactivate. And some of these infections include hepatitis B, hepatitis C, HIV if it's not well treated, cytomegalovirus, so CMV, EBVs. So these are some of the common viral infections that a person can get if their immune system is too weak. And these are some of the infections that we will check for even before transplant because we want to know if a person has been exposed to these infections earlier in their life and whether they have immunity against these infections. After 12 months of transplant, usually the kind of infection the person gets is similar to that of the general population. So community-acquired pneumonia is very common, and during flu season, flu is very common, especially if a person was not vaccinated. So in terms of recipient evaluation for infections, we will check our recipients for infections, and all patients should be free of active infection at the time of transplantation. So anytime someone gets called in for a transplant, we will check them for infections. And if there is active infection, we would recommend that the transplant be held off and we would treat the infection and the patient would be inactivated until the infection is treated. All our transplant patients will receive some form of anti-infective agent to prevent infections immediately post-transplant. So these anti-infective agents include antibiotics, antiviral agents, or antifungal agents. And usually these stay with the patients for about 3 to 6 months until their immunosuppressive agents can be lowered. Most patients will get a urinalysis, urine culture, and chest x-ray, usually at the time of evaluation and also when they're called in for a transplant. But in addition to that, I always hear my patients complain to me, doctor, you drew 20 vials of blood from me today at evaluation. What exactly are you checking for? So a lot of times those 20 vials of blood is to check for any previous infections, whether someone has immunity against infections and whether someone has active infection. So I don't expect you to read every one of them, but basically we check for the immune status of common infections like CMV, EBV. We check patients for hepatitis B, hepatitis C, HIV, whether someone has active infection or not. If they do, they have to be treated. But in addition to that, we also check someone for their immune status. We want to know if someone is immune against certain infections. So if they're not, we can vaccinate them before transplant. Other things that we check for at the time of evaluation is occult infections. So not every one of our transplant recipients or transplant candidates were born in the US. Many of them are foreign born, and they may be exposed to infections that perhaps is not very common in the US, but is very common in their home country, for example, tuberculosis. So those are some of the other things that we would check for. We strongly recommend all our candidates vaccinate before transplant. And a few reasons why we strongly recommend that. Vaccines work best when a person's immune system is strong. We still recommend our patients get vaccinated after transplant, but honestly, vaccines don't work as well when a person's immune system is weaker. So as much as possible, we encourage all our patients to complete their vaccination series before they get transplanted. Another very important reason why we strongly encourage vaccination before transplant is post-transplant patients cannot receive live vaccines. For example, the mumps, measles, rubella vaccine. So because of that, we really would like our patients to get vaccinated before because they cannot get those vaccines after transplant. There are other special conditions that we need to consider for certain patient population. For example, a person who doesn't have a spleen is more prone to infections from certain bacteria, like encapsulated organisms. And in those situations, these patients may need antibiotics after transplant when their immune system is suppressed. Other patient population may need special medications that suppress their immune system even more than the regular immunosuppressive agents, and they may need more anti-infective agents after transplant. So these are all the things that we have to evaluate for before transplant. These are the vaccines that we strongly recommend our patients get before transplant. And like I said, part of the reason is because they work better before transplant, but the other part of the reason is, for example, the live vaccines cannot be given after transplant. COVID is a new disease. COVID is a disease that we've known for, about 4 years now. So we know that our kidney transplant recipients are at very high risk for poor COVID-19 outcomes due to their immunosuppressed state. And this is especially true at the beginning of COVID when we didn't have vaccines available. The risk of death is estimated to be 1.5 times that of the general population with very similar comorbidity, so very similar medical conditions. All our candidates are tested for COVID at the time of kidney transplantation, and all the donors that are procured are tested for COVID as well. Now, we know a lot about COVID these days that we didn't know at the beginning of the pandemic. So, at the beginning of the pandemic, we rejected all organs from donors that were COVID positive. But that's actually not true anymore. There's been a lot of case reports of successful transplantation of kidneys, of hearts, um, from COVID positive donors with no evidence of viral transmission after transplant. So we do talk to our infectious disease specialists before we say no to any organs that are COVID positive these days. And obviously, the reason is we really need to increase our organ supply so that all our patients can get transplanted. Just a word about vaccine mandate. At the beginning, when the vaccines first came out, some transplant centers actually mandate vaccination for COVID. And it was a huge controversy because some patients who refused vaccination could not proceed with their kidney transplant process. Again, vaccination, including COVID vaccination, is something that we strongly encourage our patients do before transplant. And the American Society of Transplantation basically recommends that each institution should have an institution policy regarding vaccination. I think what is more important is each transplant center needs to be transparent about what their policy is and convey the message to the patients in terms of whether they need the vaccination before they can get the transplant or not. I just want to spend a few minutes talking about hepatitis C because it's actually a very unique disease. Patients who are infected with hepatitis C used to have very poor outcomes after kidney transplant. And the reason for that was because the treatment for hepatitis C used to be very ineffective. Not only was it ineffective, it actually increases the risk of rejection for anyone with a kidney transplant or any type of solid organ transplant. But that's actually not true anymore. Today, we have very effective treatment for hepatitis C. In fact, it is 99.8% effective for the eradication of the hepatitis C virus. So the outcome of our hepatitis C patient is no longer as bad. In fact, we right now debate when we treat our patients for hepatitis C. Do we treat them before transplant? Do we treat them after transplant? And really, it depends on when do we think a person can be transplanted. If a person can be transplanted fairly soon, then we don't want to hold up the transplant. We would recommend the person get transplanted and then be treated for the hepatitis C. Now, if the wait time for a transplant is going to be very long, then we would recommend that the patient be treated for hepatitis C first before getting a transplant. Now, of course, if the hepatitis C has caused significant liver disease, as I've mentioned earlier in the lecture, then perhaps they need a simultaneous liver kidney transplant. But the other thing that I want to mention here is also, again, because the treatment is so effective these days, we actually don't shy away from hepatitis C infected organs anymore. In fact, your doctor may talk to you about whether you want to take a hepatitis C infected kidney. And while it seems daunting, we have to remember the treatment is so effective these days that even if that organ can transmit hepatitis C to someone who's not otherwise hepatitis C positive, the treatment is so effective that it's been done, and many patients can be effectively treated post-transplant with at least what we know of as no long-term side effects for now. So it is something that your doctors may talk to you about whether you want to consider. So in conclusion for this part, any active bacterial, viral, or fungal infection will preclude kidney transplant, and any patients who are on the wait list will be taken off until the infection is treated and controlled. All potential transplant candidates should be vaccinated prior to transplant, and if they received a live vaccine, then the transplant needs to be postponed for at least 4 weeks. Anyone with chronic infections such as hepatitis B and HIV should be treated before transplant, and there should be documentation of sustained response to the treatment before the patient can be transplanted. But the exception is hepatitis C, as I've mentioned before. COVID-19 infection confers a high mortality rate and complications in the transplant population and candidate is high. So patients are strongly encouraged to be vaccinated before transplant. Now let's talk a little bit about cancer screening before transplant. We know that cancer is very common in our end-stage kidney disease population, especially the urogenital cancer. So for example, the kidney cancers and the bladder cancers, as well as endocrine cancers such as thyroid cancer. The risk of cancer seems to be increased in our post-transplant population as well. It's believed to be 3.5 times that of the general population. And the reason for that is because number one, the immunosuppressive agents that we use sometimes can damage DNA, and this increases the risk of patients to cancer. The second reason is when the immune system is suppressed, the body's ability to fight cancer is lower. And because of that, the risk of cancer is higher. But the third reason is when the immune system is weaker, a person is more prone to infections. And some of the infections, some of the viruses can also cause cancer. So it increases the risk of patients getting infection by viruses that can cause cancer and hence increase the risk of cancer. So we do screen our patients for cancer before transplant, and the cancer surveillance in our dialysis and pre-kidney transplant population is usually extrapolated from the general population. In other words, we don't have a set of special screening for our dialysis and transplant population. We just follow what the general population do. So basically what your primary doctor is telling you to do for your cancer screening is what we're doing for our dialysis population as well. And what this means is in a woman whose age 40 years and above will start breast cancer screening. Women will have cervical cancer screening when they become sexually active or above the age of 21. A male or female above the age of 40, 45 will receive colon cancer screening. Someone who's a heavy smoker will receive lung cancer screening. In terms of prostate cancer screening, the guideline is currently changing, so it's a little bit center dependent. So again, talk to your center about what the screening recommendation is. The one that is a little bit unique is genitourinary cancer. So cancer of the kidney and cancer of the bladder. This is not done in the general population, but our kidney disease population have a higher risk of kidney cancer, such as renal cell carcinoma, and also bladder cancer. And because of that, we do screen our pre-kidney transplant population and our dialysis population for kidney cancer and bladder cancer, usually either with a CT scan or with a cystoscopy. Another common question that I often get asked is, Doc, if I get a cancer, if you find a cancer in me, how long do I have to wait before I can get a kidney transplant? Here, I'm showing you two sets of guidelines. On the left side is the KDIGO guidelines, and on the right side is the guidelines from the Australian New Zealand Society of Nephrology. And if you read them very closely and you compare them very closely, you may see slight differences between the two sets of guidelines. So oftentimes the decision is dependent on the discussion between the oncology team, the transplant team, and the patient. But in general, the rule is the more advanced a cancer is, the longer a person has to wait. The more localized a cancer is, and if the doctor can resect the whole cancer, for example, squamous cell cancer of the skin or basal cell cancer of the skin, if the cancer can be fully resected and it's discovered early, sometimes there's no wait time, or even if there was a wait time, it's usually a fairly short wait time, like a year or two. So again, whether we transplant someone or wait a while before we transplant them is a balancing act. So we want our patients as much as possible to come off dialysis so they can reap the benefits of kidney transplant. But at the same time, we also have to weigh that against the risk of transplanting someone too early after their cancer diagnosis and risk the cancer spreading. So again, this becomes a discussion to be had between the transplant team, the oncology team, as well as the patient. So in summary of this section, we know that kidney transplant candidates are often asked to undergo age-appropriate cancer screening as part of the kidney transplant evaluation process. There are usually no special cancer screening guidelines for our kidney disease patients, and we just follow that of the general population. Patients with a history of cancer often have very specific wait periods before they can undergo a kidney transplant, and often this is guided by a discussion between the oncology team, the transplant team, and the patient. In addition to the medical workup that I've talked about, patients will also undergo a psychosocial evaluation by the social worker. They will undergo a financial counseling session with the financial counselor, as well as evaluation by the dietitian and the pharmacist. So only after all these evaluations are done, so once all of this workup is done, then a kidney transplant candidate will be presented at the selection committee. And if everyone agrees that all the workup is complete and all the workup is good to go, then the person will be placed on the wait list. And there are separate sessions that we will have to talk about what it means to be on the wait list and what it takes to stay active on the wait list. So finally, I just want to spend a little bit of time talking about what to know when someone is thinking about becoming your living donor. As many of us know, living donor kidney transplants provide better kidney survival compared to deceased donor kidney transplant. So this is a study that was published in 2021. And what the study did is compared graft survival. So compared the kidney survival between those who received a living donor kidney transplant compared to those who received a deceased donor kidney transplant. And what you will see here is compared to those who received a deceased kidney transplant, as shown in the light blue line here, and also actually the dark blue line is deceased donor kidney transplant. The light blue line is the patients who receive what we call a Eurotransplant senior program. So kidneys of older donors in Europe. Patients who received a living donor kidney transplant, as shown here in this red line here, have better kidney survival, better graft survival compared to someone who received a deceased donor kidney transplant. However, the patient survival is relatively comparable between the three groups. So some facts about living donor kidney transplant. We know that living donor kidney transplant is when a living person donates one of their healthy kidney to a person with advanced kidney disease. A living donor can be a family member, either a parent, a child, a sibling, and these are known as living related kidney transplant, or it could be from a friend, a coworker, a neighbor, a member at the place of worship, or even a stranger. These are known as living unrelated kidney transplant. And the benefit of living donor kidney transplant includes a shorter wait time, more predictable schedule because we do schedule living donor transplant as opposed to deceased donor transplants. And as I showed you before, better kidney survival. So what are some of the things that you should know as a kidney transplant candidate if someone says they want to be your living donor? One of the most important thing that I always tell my patients is please provide the donor with the contact information or the link of the transplant center so that they can contact the transplant center. And the reason for that is to ensure that there is no coercion involved. The transplant centers usually will not voluntarily contact the potential donor. And as mentioned, the reason for that is we don't want the donor to feel pressured into donation. No one should ever feel pressured that they need to give up their kidney. Really, this is a voluntary act, and we like the donor to contact us to show that they want to do this willingly. Usually the donor workup will not start until the kidney transplant candidate workup is near completion. It doesn't have to be completed, but it should be somewhere along the way before we would start the donor workup. And the reason for that is usually because we want to make sure that the candidate could be a potential kidney transplant candidate before we start the donor workup. The other thing that's very important to know is the donor team usually works separately from the recipient team, as both teams want to ensure the best interest of their patient is safeguarded. Sometimes I have candidate patients ask me, I don't understand. My brother said he wanted to be a living donor. He's contacted the transplant center, but I don't hear anything. No one tells me anything. And actually, it is really on purpose that no one tells you anything because we really want to make sure that the team who's working with the donor has the donor's best interest in mind and they will not divulge any information about the donor to the candidate. The other reason we want to do that is because we want to make sure that the donor doesn't feel pressured. The donor at any point in time during their evaluation process should feel comfortable saying, I'm not comfortable proceeding with this evaluation. I want out. And because of that, we keep the two evaluations separate. The living donors also undergo extensive evaluations. They usually undergo a medical evaluation, a psychosocial evaluation. They also undergo financial counseling. And if they're deemed to be a suitable donor, then we do compatibility testing between the donor and the candidate. And one of the things that I really want to emphasize is the transplant team really appreciates the generosity of our living donors. And we really do everything possible to safeguard the safety and the health of our donors. This is something I hear a lot from my kidney transplant candidate patients is they feel guilty. They feel that, they're risking someone's health by asking them to donate an organ. But I often also tell my patients that, look, the responsibility is as great on the transplant team. We are the ones who need to make sure that someone is a suitable donor and someone will be safe and healthy after donation. So, one of the things that is very important to share with everyone is that we will make sure that our donors can actually donate before we agree to let them donate. Here's some of the resources that is available on the website. So the NKF has a wonderful website on becoming living donors. So it has information on how to become a living donor, and as Doris mentioned earlier, there's the kidney donor community, NKF Care. So if someone wants to be a living donor and wants more information, here's some information that you can share with the potential living donor. So in summary, a kidney transplant offers the best survival and quality of life for patients with advanced kidney disease, except for those with absolute contraindications. Patients with relative contraindications should be treated for their reversible condition prior to being referred for a kidney transplant. A kidney transplant candidate should be referred at least 6 to 12 months before their anticipated kidney replacement therapy initiation to allow for adequate time to evaluate for potential living donors and for possible preemptive kidney transplant, meaning transplant before needing to start dialysis. Here's the workup that I talked about for a kidney transplant evaluation. And finally, it's never too early to think about finding a living donor. And if a person has a potential living donor, please provide them with the contact information of your transplant center so that they can contact the transplant center. And with that, I thank you for listening, and I am happy to take any questions.
Okay, well, thank you, thank you. Such great content. Thank you, Dr. Ng, for all of that. So we have about 10 minutes left. And what I would like to do now is to invite Jackie and Dr. DeCastro to come on as well. There's a whole conversation taking place in the QA. And if you're following the presentation, then you're probably not following that conversation going on. Not to worry. We will share all of that in the follow-up email as well. But right now, I would like to ask let's start with Jackie. If you can highlight maybe one or two of the questions that you answered that are most common that you hear among your patients that you can answer and share that right now and any takeaway you'd like.
we did have a lot of questions there were questions about cancer. And, the thing to always remember, all of the information that Dr. Ng gave is amazing, but the most important thing is to stay in close contact with your transplant center because
Mhm.
each center has different guidelines for how they move forward. So that's why you may see in the Q&A, we can't say, well, this is how many years for this kind of cancer, and this is how many years for that. It depends on the individual. It depends on the treatment that you've had. It depends on what your oncologist says is your 5-year likelihood of recurrence. So with that, with literally everything, while we can cover the generalities of what an evaluation is made up of, um, who qualifies, who doesn't. It's really going to be based so much on your individual transplant center and your individual situation. So that's one thing to keep in mind. And also, um, communication with your transplant center is huge. Um, know that they will always be happy to answer your questions, but they need to hear from you. So if you change your phone number, if you were hospitalized, anything like that, and you're in process with the transplant center, these are the kinds of things always to remain in contact with throughout your evaluation and workup. So that would be my few cents.
Hmm. Great, thank you so much. Actually, before we go to Dr. DeCastro, I'd like to address some of the questions that were in the QA section that have not been answered. Great presentation. Can you discuss kidney paired exchange? Who wants to take that? Dr. Ng, you want to take that?
I can take that. I suppose the question is, what is what
Yeah,
is
let's
kidney
start with
paired?
that.
All
Yeah,
right.
maybe just a basic. Yeah,
Right. So
yeah.
kidney paired exchange is something that has been going on actually very actively over the last couple of years. And what it is in the past, we used to have people bring in their donors, but up to 30% of donors are actually not suitable for the recipient, whether it's because of blood group incompatibility, or because they have positive cross match, meaning they have antibody against the donor. So, and 30% is a lot of, pairs. So what we have done, or what the transplant committee has done in the last couple of years, is start a paired exchange program. And the easiest way I explain to my patients is, for example, if I have a donor, I need a kidney, and I have a donor, but my donor and I are not of compatible blood group. But I know there's another pair, or I wouldn't know, but my transplant center knows that there is another pair that perhaps they are also not compatible, but they know that that donor is compatible with me, and my donor is compatible with that candidate. So then we would do a paired exchange. So my donor donates to that candidate, and the other donor donates to me. This is a very simple explanation of a paired exchange. These days, the paired exchange doesn't necessarily have to be between one pair. It could be between 30, 40 pairs. It can be national paired exchange. So there is a lot of logistics going on, but the easiest way to understand is just exchanging kidneys from donors that are not compatible.
Yeah, yeah. Go ahead. Were you going to say anything else
Oh,
to
I,
that?
I was gonna
Yeah.
say, if it is something that is of interest, definitely talk to your transplant centers.
Hmm. Yeah, great. Thank you. Yes, that is a very important program. I hear that a lot. I myself am a part of a kidney swap. 5 recipients, 5 donors. I'm here on the West Coast. My donors, not actual donor, but my friend gave his kidney to somebody in New Jersey. So that kidney, I call him my Superman, and his kidney flew to New Jersey. So yeah, think of that. Um, and just to note, we will have a webinar in the future on living donation for living donors, what that process, and that will include a deeper conversation on the paired exchange program. So thank you for that. Dr. Castro, would you like to share maybe one question from the QA section that was asked, and maybe any takeaway you'd like to leave with our audience today?
Yeah, I think in the Q&A, it's actually, it's not answered yet. Is with regards to, is there a cutoff age for as a recipient? You know, I get that asked often. I have, for example, 70-year-olds or older coming in like, I did not know that, you know, I can be evaluated for a transplant. I'm just too old. So the straight answer is some programs might have a cutoff, but majority do not. So um, these days, especially because the kidney care these days is improving. So a lot of the patients developing progressive kidney disease or kidney failure are relatively older, you know. So what we do is, you know, we evaluate them in transplant. I mean, although we know in reality, as folks get older with their comorbidities, of course, they stack up. You know, that's a reality, and that's what the workup is for. So we don't usually put like an age cutoff. So in our center, I would say, you know, we've transplanted folks older than 80, but in all reality, they're relatively robust with not a whole lot of comorbidity 80-year-old, because you really have to balance that benefit risk, you know, depending on the evaluation. Do you think they would really benefit from undergoing the workup and the medications as opposed to just, staying on dialysis? And sometimes they like the community on dialysis. They like the structure and stability of that. So there's no particular age cutoff. We evaluate them and let you know if there's a comorbidity burden that we're concerned with. The other piece, just in line with the other comment or recommendation I have as a tip, with regards to centers, you know, we send packets and we have videos in terms of information before we see them for their initial visit for referral. If you can encourage, you know, your providers and patients to read those packets so that when they come in, you know, they can ask their questions and they can make the most out of that visit. You know, and yeah, the communication between the provider, the centers, and the patients is really important. So I advise the patient, even when I'm seeing them, you know, look for centers that you really have, you know, good vibes or rapport with, because that really will help you.
Oh,
I guess comments I have.
Okay, wonderful, wonderful. So maybe we have time for one more question. I see. So some of the age-related questions, a lot of that was also addressed in the last webinar. So we will also include a recording to that webinar. A lot of questions about age came up there.
I would tag on one last thing with regards to the age. I second everything that Dr. DeCastro said. In addition, one of the things that might be of consideration at any given center is the length of time somebody is likely to have to wait on a transplant list. So, for example, somebody may apply and be 70 and be of good health and a transplantable patient right then, but the transplant center is also taking into account if they have to wait 8 years, how good are they going to do? Are they still going to be a candidate? So our emphasis is always on living donation, because if you're 70, 71, 72, 73, whatever it is, and you are eligible to be transplanted, we want you to get transplanted as soon as possible. And that's always going to be through living donation.
Wonderful. Okay, so we have 1 minute left, and so we are out of time. I see a few more questions that are unanswered. We will include that in the follow-up email with all the answers. So we have 3 experts here who will be happy to chime in. So thank you so much. So thank you to the 3 of you, Dr. Yue-Harn Ng, Iris DeCastro, and Jackie Ferris, and our webinar planning team, and my wonderful team for supporting this, but all the behind the scenes that goes on. And if, you know, recently we discovered the react function in Zoom. So it's down at the bottom with the heart. So just feel free to show your appreciation to our speakers today. Reminders follow-up email will include the recording, all resources mentioned, recording to previous webinar. And we saw that today's webinar leads to many more questions and future topics, including living donation, and also post-transplant. What happens after post-transplant? What issues arise? For some of us, we think it's perfectly drama-free and boring in a good way, but that's not always the case. So we will have a webinar on that. Questions and answers will be included, and we will have another webinar in August on the financial considerations of kidney disease. So be on the lookout for an email for email about that. Please fill out the feedback survey for today's webinar. The link is in the chat. Your input is very important. It always helps determine what our future topics will be. So with that, I just want to say thank you. Have a great afternoon. We wish you all good health and hope to see you in August. Thank you so much.